Good morning or good afternoon. This is Claire Brindis, and I'm very delighted to be part of this webinar. And I'm really excited about next slide, to spend a little time with our listeners to focus on what can we learn from Healthy People 2010 as we embark on this very important journey together across our country to reach and target the Healthy People 2020. So this part will be focusing on building a bridge for advancing an adolescent health agenda. And I'm particularly pleased that adolescents are now fully recognized as an important group for consideration in all of our strategic planning. Thus, I'm going to be spending a little time providing some background on what happened with Healthy People 2010, and in particular, 21 adolescent critical health objectives that we have been working on across the nation, and how our lessons learned there can help set the stage for Healthy People 2020. I'll spend a little time talking about the progress in fulfilling those objectives from a national perspective and some variation among states, as well as hoping to give you some ways that national and state data can be used to improve the health, safety, and well-being of adolescents and young adults. Next. We've started to touch a little bit on why this unique focus. This is clearly a key transitional and dynamic period in the life course, and it's important to be focusing on adolescents and young adults themselves as they go through these years, because they represent such an important growth. It's some of the most important change that occurs since the very early childhood of that individual. And so it's important to think about this period, but also to be thinking about the longer-term consequences. So there's tremendous physical, social, emotional, and cognitive growth and development. And this is the period when young people are developing lifelong habits, behavioral patterns, and relationships that influence those lifelong health outcomes. We also need to recognize that our country is undergoing a major revolution in terms of not only the growth in the number of young people in our society, so that by the year 2050, we anticipate that they'll be reaching about 56 million young people, a 34% increase from the year 2000, but it's also going to be an increasingly diverse population that we will be responsible for assuring successful outcomes. Thus, health promotion, primary prevention, and secondary interventions during this period can have profound and positive, lasting health, educational, and economic effects, not only on the young people and their families, but society in general. Next. When we think about Healthy People 2010, looking back with 2020 hindsight, we see that the roadmap of a comprehensive set of national disease prevention and health promotion objectives that measure the nation's progress over time was the major agenda for this effort. And there were two overarching goals as compared to the overarching goals that have just been described for 2020. In 2010, those goals focused on increasing quality and years of life, as well as eliminating health disparities. And clearly these two goals are an important component as we move forward into the 2020 objectives and goals. Next. In the 2010 objectives, when we looked at the 467 national health objectives, we were able to call out that about 107 were important for adolescents and young adults. And within that, the CDC, the Division of Adolescent and School Health, brought together a national consensus work group to begin to highlight some very specific subset of these objectives, and we came up with 21 critical adolescent and young adult health objectives for the 21st century. Next. And when we think about those 21 critical objectives, they really clustered into 6 health and safety domains: mortality, unintentional injury, violence, mental health and substance abuse, reproductive health, as well as the prevention of adult chronic diseases. Next. When we critically review did we really make a difference in adolescent health during this last decade? It's important for us to recognize and to hold a mirror to what happened. We were able to achieve only 2 of the 21 adolescent health critical objectives. The first was a reduction in the proportion of adolescents who reported driving with a drinking driver, and the second was reducing the proportion of adolescents involved in a physical fight. Next. In the area of mortality, we found that only one age group, young adolescents ages 10 to 14, were able to achieve the target for decreasing the overall mortality rate. Among 15 to 19-year-olds, there was some improvement, but not significant. And among 20 to 24-year-olds, there was a worsening of the mortality rates. I do want to make a point here that as the committee looked at all of these 21 critical objectives, we agreed on the definition of adolescence and young adulthood to represent the age periods of 10 to 24. So you can see that we clearly cover a whole continuum of some very critical age spans. Next, looking at specific health status outcomes, in this decade review, we were able to demonstrate some uneven progress in several key areas when we compared to the baseline data that we were trying to build upon and also the 2010 objectives we were trying to achieve. So, for example, in the area of teen pregnancy, there were significant decreases across our country. There was also a decrease in tobacco use, a more modest decrease in the use of illicit substances, such as marijuana, and an increase in safety belt use. When we look at the objectives pertaining to physical activity, there was no significant change. And unfortunately, when we look at the area of adolescent overweight and obesity, in fact, there were increases among young adults who experienced these health outcomes. Next. So, the response to the question of, did we make a difference? I think it's important to point out that there was substantial variation across gender, racial, and ethnic groups, as well as geographic variability. So, for example, in the area of mental health, young women are more likely to report an attempted suicide or major depressive episode compared to their male counterparts. But the rates of completed suicide among adolescent and young adult men are 3 times greater than those of female adolescents and young adults. In another area, for example, young men are twice as likely to report physical violence at school or carrying a weapon on school property as compared to young females. We also have to recognize that our ability to capture data on subgroups of adolescents who are potentially at high risk for negative health outcomes has also been restricted. So, for example, for some groups, demographically defined, for example, through poverty level, or whether you define them legally, young people who are involved in foster care or young people who are incarcerated are some examples, or perhaps some subgroups of young people who through some of their chronic ill conditions or an eating disorder, or perhaps other special populations such as the homeless, pregnant and parenting, and immigrant youth. So nationally representative data for subgroup data available, there was only 36% of the 21 critical health objectives that had this kind of subgroup data available. And so it's important to be thinking about the variation in data and thinking about specific populations who may be particularly at risk for encountering even worse outcomes, as well as considering groups that may be doing better than national trends.